يلا لنبدأ.
أستاذ هاي شنو مخرج فوق؟
اوكي سماكو مشكلة بابا ليندا.
Okay, تمام. My seminar today is about the trachea and the lungs. The trachea is a tube-shaped structure, 15 cm long and 2 cm in diameter. It is made up of 15 to 20 incomplete rings of cartilage that are bridged posteriorly by the trachealis muscle. The trachealis muscle encircles the trachea completely, but it is most prominent posteriorly due to lack of cartilage. This is the trachea, and these are the tracheal cartilages. The trachea begins at the lower border of the cricoid cartilage at the level of C6 vertebra. This is the cricoid cartilage at C6 level and extends to the level of carina at the level of sternal angle. This is the sternal angle and the level of the carina, which lies at T5 level, T4 on inspiration and T6 on expiration. So it extends from C6 till T5. The relations of the trachea, we have two parts, the cervical and the thoracic part. The cervical part is bounded anteriorly by the isthmus of the thyroid, anterior to the second, third, and fourth rings. This is the trachea, and this is the thyroid. This is the isthmus, which forms an anterior boundary. Second is the inferior thyroid veins, and the strap muscles, the sternohyoid and sternothyroid. As it is shown here, this is the trachea, and this is the thyroid, the strap muscles anteriorly, and the isthmus forms an anterior boundary. Posteriorly, we have the esophagus. This is the esophagus and recurrent laryngeal nerves. And laterally are the lobes of the thyroid gland. These are the lobes, and the common carotid artery within the carotid sheath. The thoracic part is bounded anteriorly by the brachiocephalic artery and the left common carotid artery and left brachiocephalic vein. As we can see here, this is the trachea. This is the left brachiocephalic vein. This is the right brachiocephalic vein forming the superior vena cava. The left forms an anterior boundary to the trachea. And this is the aortic arch, which gives three major branches. And the brachiocephalic artery, this is the brachiocephalic artery, and the left common carotid artery forms an anterior boundary. Posteriorly is the same to the cervical part. We have the esophagus and left recurrent laryngeal nerve. On the left lateral, we have the arch of the aorta and the left common carotid and the left subclavian artery. On the right lateral side, we have the brachiocephalic artery, the right vagus nerve, the arch of the azygos vein, and the pleura. The blood supply of the trachea is divided into two parts, upper part and lower part. The upper part is supplied by the inferior thyroid artery, which is branched from the thyrocervical trunk branch from the subclavian artery. The lower part is supplied by branches of the bronchial artery. These are the bronchial arteries supplying the lower part. The venous drainage is to the inferior thyroid venous plexus. This is a frontal chest X-ray showing this is the trachea, and it is divided into right and left main bronchus. On lateral chest X-ray, this is the trachea, which is seen as in the midway between the sternum and the vertebra. We have a right paratracheal stripe and posterior paratracheal stripe. The right paratracheal stripe, it represents the right tracheal wall and the adjacent pleural surfaces and any mediastinal fat in between. This is the right paratracheal stripe. It is seen due to air within the trachea and air within the lung. It extends from the level of the clavicle down till the tracheobronchial angle. This is the tracheobronchial angle. It should be less than 3 mm, while in the left side, the tracheal wall is separated from the lungs by the aorta and the major vessels, so it cannot be seen. Posterior tracheal stripe is formed by air in the trachea and air in the right lung, outlining the intervening posterior wall of the trachea and soft tissue. It is also less than 3 mm in width. This is the trachea, and this is the posterior tracheal stripe on CT. On lateral chest X-ray, this is the posterior tracheal stripe. If the collapsed esophagus is opposed to the posterior tracheal wall, the stripe may measure up to 1 cm. Now the bronchi. The carina is defined as the anterior-posterior ridge at the junction of the main bronchi that is at the level of T5, and which is the level of the sternal angle. The carinal angle, this is the carinal angle, it measures 65 degrees, and this angle is 20 degrees to the right side of the midline and 40 degrees to the left. This angle is slightly larger in children, and it increases by about 10 degrees to 15 degrees in recumbency. What is the significance of this angle is that widening of the carinal angle, as shown in this image, above 65 degrees may represent a left sign of many pathologies, including left atrial enlargement due to mitral valve pathology, or subcarinal masses, lobar collapse, cardiomegaly, or pericardial effusion. Now the right main bronchus, it is called arterial because it passes above the right main pulmonary artery. It is 2.5 cm in long, 1.5 cm in wide. It is wider, shorter, and more vertical than the left one. The relations are, first, this is the right main bronchus. Anteriorly, we have the superior vena cava and the right pulmonary artery. This is the superior vena cava, and this is the pulmonary trunk divided into left and right. So the superior vena cava and the right pulmonary artery forms an anterior boundary. Posteriorly, as shown in this image, we have the azygous vein, and the arch of azygous vein forms a superior boundary. This bronchus is divided as it passes into the lung into an upper lobe bronchus and bronchus intermedius. The upper lobe bronchus further subdivided to supply the bronchopulmonary segments into apical, posterior, and anterior. Then the bronchus intermedius continues downward to further subdivide into middle and lower lobe bronchus. The middle lobe bronchus is divided into lateral and medial, and the lower lobe bronchus is divided into superior segment and 4 basal segments, which are the lateral, posterior, anterior, and medial segments. Now, the left main bronchus is called hip arterial because it passes under the artery. This is the left main bronchus. It is 5 cm long and 1.2 cm in diameter. The relations are anteriorly, we have the pulmonary trunk. This is the pulmonary trunk. As we said, it passes above the bronchus. And posteriorly, the esophagus and the descending aorta. Superiorly are the aortic arch and pulmonary artery. This bronchus is divided into 2 parts, the upper lobe bronchus and lower lobe bronchus. The upper lobe bronchus divisions are the same to those in the left, except that the apical and posterior usually have a common apical posterior origin, which will then subdivide. And then we have the lingular. Here the lingular arises from the upper lobe, which divides into superior and inferior. Then the lower lobe bronchus, which is divided into superior and basal segments. The difference here is that we do not have medial segment in the left side. The blood supply to the bronchus is from bronchial arteries, which are branches from the thoracic aorta at the level of T5, 6. These are usually one on the right and two on the left, but they have variable origin. The bronchial veins drains the bronchus, drain into the right to the azygous system. On the left, drains to the hemiazygous system. These are the bronchial arteries. This is a frontal chest X-ray showing the trachea, the right main bronchus, the left main bronchus, and this is the carina. On lateral chest X-ray, this is the trachea, and this is the bronchus, bounded anteriorly by the right pulmonary artery anterior to the bronchus, and the left pulmonary artery posterior to the bronchus. On CT image, we can see this is the trachea, the right main bronchus, the left main bronchus, and the right is divided into upper lobe bronchus, and this is the bronchus intermedius, which will then further subdivide into middle and lower. This is the left side, the left main bronchus, which will divide into upper lobe bronchus, and the lingular segment, which arises from the upper lobe. It is divided to superior bronchus and inferior lingular bronchus, and this is the lower lobe bronchus. Now, the lungs are described as having four surfaces: the apical surface, the costal surface, the mediastinal surface, and this is the diaphragmatic surface. The right lung has 3 lobes, while the left has only 2 lobes, with the lingula of the left upper lobe corresponding to the right middle lobe. As we can see here by frontal and lateral chest X-ray, in the right side, in the right lung, we have 2 fissures, the minor fissure and the major fissure, dividing the lung into upper lobe, middle lobe, and lower lobes. This is the upper lobe, right upper lobe above the horizontal fissure. This is the right upper lobe above the horizontal fissure. And then we have the right middle lobe, and this is the right middle lobe between the horizontal and oblique fissure. This is the right lower lobe, and this is the right lower lobe posterior to the major fissure. On the left side, we have only major fissure. There is no horizontal fissure, so we have left upper lobe and left lower lobe, as it is seen here. This is the left upper lobe on frontal and lateral chest X-ray, and this is the left lower lobe on frontal and lateral chest X-ray. We have what is called lung zones. These zones are useful when describing the location of pathology on frontal chest X-ray only. However, the use of these zones is not used in CT because the lobar and segmental anatomy is more precise. What are these zones? We have 4 zones: the apical zone above the clavicles, the upper zones between the clavicles and the heart, the mid zone at the level of the hilum, and the lower zones at the lung bases. On this chest X-ray frontal view, we can see this is the apical zone on the right and left above the clavicles. This is the upper zone on both sides between the clavicle and the heart. These are the mid zones at the level of the hilum, and below which are the lower zones. On CT, image, we have 3 levels: the level of the trachea, this is the trachea, the level of carina, where we have the right and left bronchus, and the level of the heart, this is the heart. First level is the level of the trachea. At the level of the trachea, this line, the right line, is passing only through the upper lobes. So what we have here is the right upper lobe and the left upper lobes only. Second level is the level of the carina. This line, this red line, is passing through the upper part of the oblique fissure. So what is seen anteriorly is the upper lobe, and what is seen posterior to this fissure is the lower lobe. Here we can see this is the carina, dividing the lungs equally on both sides into upper lobes. Here this is the right upper lobe, left upper lobe, and right lower lobe, left lower lobes. The third level is the level of the heart. At the level of the heart, we have this red line, which passes through the lower part of the oblique fissure. So anteriorly, we have the middle lobe on the right side. On the left side, we have the lingula of the left upper lobe, and posterior to this line is the lower lobe on both sides. So this is the level of the heart, which divides the lung into anteriorly 1/3, represents this is the middle lobe, this is the lingula of the left upper lobe, and posteriorly we have the right and the left lower lobes. So these sections show the lobes of both lungs. This is the level of the trachea. Again, these are the right and left upper lobes. At the level of the carina, we can see the right upper lobe and the left upper lobe, and the right lower lobe and the left lower lobe. And this is the upper part of the major fissure, which divides them. Then the third level, which is the level of the heart, we have the lower part of the major fissure, dividing, this one and this one, dividing the lung into middle lobe and lingula of the left upper lobe and both lower lobes. Sometimes this line passes, sometimes this cutting line passes through both fissures, and more superiorly here. So here what we'll have on the right side is the upper lobe, middle lobe, and lower lobe, as it is shown here in this image. This is the horizontal fissure, and this is the oblique fissure. So we have the three lobes together seen. Now, regarding the bronchopulmonary segments, as we said previously, the bronchus is divided into right and left, and each one of them divided into many segments that will supply the corresponding lung segments. So this is the right lung, this is the left lung. In the right lung, this is the upper lobe, this is the middle lobe, this is the lower lobe. The upper lobe is divided into anterior segments supplied by the anterior bronchus, apical, and posterior. The middle lobe is divided into two segments, lateral and medial. The medial segment near the heart, and the posterior, which are the superior segment, and the basal segments are anterior. This is the anterior, this is the medial and lateral, and this is the posterior. This is the right lung. In the left lung, we have two differences. First, that there is an apical posterior segment, single segment, and the second difference is that we do not have a medial segment, only lateral segment. So if we return to our cross sections, this is the level of the trachea. At the level of the trachea, we have only upper lobes. So if we see through this line, in the right lung, this line divides the lung into three equal segments. Anteriorly, the anterior segment, this is the anterior segment, this is the anterior segment. The apical, here it is the apical, and the posterior segment, this is the posterior segment. On the left lung, this line is dividing the lung into anterior 1/3, which represents the anterior segment, and posterior 2/3, which represents the apical posterior segment. These both are the upper lobes only. Second level is the level of the carina, which divides the lung equally into upper lobes and lower lobes. So if we can see, this level is passing through the carina, is passing on each side. This section is the same on each side. It is passing through the anterior segment only of the upper lobe. This is the anterior segment of right upper lobe, anterior segment of left upper lobe, and passes posteriorly only through the superior segment. So this is the superior segment, and this is the superior segment of both lower lobes. The third level is at the level of the heart. We say this level, we have this orange line dividing the heart into anterior 1/3, the middle lobe, and this is the lingua of the left upper lobe, and posterior to it are the level of the lower lobes. Now, if we see this line passes through the basal segments only of the lower lobes on both sides, only the basal are seen, divided into four parts on the right and 3 parts on the left. This is the anterior segment, corresponds to this one. This is the lateral segment, this is the medial segment, and this is the posterior segment. On the left side, the same, but we do not have medial segment. This is regarding the basal segments of the lower lobe. The anterior section passes through the middle lobe. So this is the middle lobe. It will be divided by a line into medial, the medial segment near the heart, and lateral segment. This is the medial, this is the lateral segment. On the left side, the lingua is further subdivided into inferior segment. This is the inferior segment, and this is the superior segment. The inferior and the medial are near the heart. This is again the division of the middle lobe into medial and lateral, and the division of the lingula into inferior and superior. This is a rapid revision of the segments, showing this is at the level of the trachea. We have the right upper lobe, left upper lobe, the right upper lobe. We have the anterior, apical, posterior. In the left upper lobe, we have anterior and apical posterior. Second section at the level of the cranium, we have on both sides, this section is similar on both sides. We have only the anterior segments of right and left upper lobe and the superior segments of both lower lobes. The third level is at the level of the heart, and we say this major fissure dividing into medial and lingular and lobes, and this is the lower lobe of both sides, which is further divided into anterior, into lateral, medial, and posterior. On the left, anterior, lateral, and posterior, and the middle, which is further divided into medial and lateral, and the lingula, which is divided into inferior and superior. Now, regarding the lung lymphatics, we have the bronchopulmonary nodes within the lung substance. This is the pulmonary nodes. Second are the bronchopulmonary nodes at the level of the hinum. These are the bronchopulmonary nodes at the level of the hinum. We have the carinal lymph nodes below the hinum, and then the tracheobronchial lymph nodes above the tracheobronchial junction, and right and left paratracheal lymph nodes. These lymph nodes, the bronchopulmonary, drains into the tracheobronchial and then into the paratracheal, and these will then drain into the bronchomediastinal lymph nodes. Lung fissures. We have 3 fissures, the major, which is called the oblique fissure, the minor, which is called transverse fissure, and accessory fissures. The oblique or major fissure is similar on both sides. It extends from the level of T4-5 posteriorly to the diaphragm anterior-inferiorly. The medial aspect of each fissure passes through the hinum. The oblique fissure is not seen on frontal chest X-ray, so on lateral chest X-ray, this is the oblique fissure, this faint line, the oblique fissure. This is the transverse fissure. The left oblique fissure is more horizontal, more vertical, and reaches the diaphragm more posteriorly than on the right. The anterior ends of the oblique fissures are 2 to 3 cm behind the anterior chest wall, and the fissures are usually undulating, so they may appear doubled or not seen entirely. The transverse fissure, this is the transverse fissure, can be seen on frontal and lateral chest X-ray. It separates the upper and middle lobes of the right lung. It runs horizontally from the hilum at the level of the fourth costal cartilage and meets the right oblique fissure at the level of the sixth rib mid-axillary line. This is the right lung, lateral view. This is the minor fissure, and this is the major fissure. We have the upper, middle, and lower lobes. While in the left lung, only the major fissure, dividing the left lung into upper and lower lobes. The fissures on CT, on conventional CT, the fissures are less visible than on plain X-ray. They are usually seen as regions of relative avascularity on the outer cortex of the lobe, where tapering of the vessels are less visible. This is the oblique fissure, the major fissure, and this is the horizontal fissure of the right lung, and this is the major fissure of the left lung. On axial section, we have this is the horizontal fissure, and this is the right and left oblique fissures. The accessory fissures includes, first is the azygous fissure. This is a downward invagination of the azygous vein through the apical portion of the right upper lobe. It therefore has 4 pleural layers, 2 visceral and 2 parietal. The azygous fissure is identified in 0.4% of PHS X-ray and 1% post-mortem. This is the azygous fissure. On chest X-ray, this is the azygous fissure. This white line is the fissure, and inferior to it is the azygous vein, teardrop appearance, and this is the azygous lobe. On CT, this is the azygous fissure and the azygous lobe. The second one is the superior accessory fissure. This separates the apical segment of the right lower lobe from the other basal segments. This is the superior accessory fissure. It separates the apical from the other basal segments. As we see, this fissure lies parallel to the horizontal fissure, so we can differentiate them. The horizontal fissure passes anteriorly from the oblique, while this one extends posteriorly. It is identified in 5% of PHS X-ray. Third one is the inferior accessory fissure. This separates the medial from the lateral basal segments. This is the inferior accessory fissure. It is called the Twinning's line, and it is identified in 8% of PHS X-ray. And there is a fourth fissure, which is called the left transverse fissure, which is rarely seen in 2% of chest X-ray. It is seen on the left lung, similar to that of the right lung. Separates the upper lobe from the lingula. Pulmonary trunks. The pulmonary trunk, it leaves the fibrous pericardium and bifurcates at once in the concavity of the aortic arch, anterior to the left main bronchus. This is the pulmonary trunk. It bifurcates into left and right under the aortic arch and anterior to the left main bronchus. It is more towards the left side. It is divided into right and left. The right is longer than the left. It passes across midline below the carina and comes to lie anterior to the right main bronchus. And then it bifurcates to give the right upper lobe artery, the right upper lobe pulmonary artery, which passes anterior to the right upper lobe pulmonary bronchus, and the interlobar, this is called the interlobar artery, which passes with the bronchus intermedius, which will further subdivide into middle and lower lobe arteries. The left pulmonary artery, this is the left one, it spirals over the superior aspect of the left main bronchus to reach to the posterior surface. It is attached to the concavity of the aortic arch by ligamentum arteriosum. This is the ligamentum arteriosum between the left pulmonary artery and between the aortic arch. The pulmonary arteries supply only the alveoli, while the bronchial arteries supply the bronchi. The pulmonary veins do not follow the bronchial pattern, but they run in the intersegmental septa. The two veins passes to each hilum from the lung tissue above and below the oblique fissures. They enter the mediastinum below and anterior to the pulmonary arteries. On the right side, we have three pulmonary veins that usually enters the left atrium separately, while on the left side, we have two veins which usually unite to enter as a single vein into the left atrium. This image, digital subtraction angio, shows the pulmonary veins draining into the left atrium. This is the right upper pulmonary vein, right lower pulmonary vein, the left upper and left lower veins draining into the atrium, left atrium. And on the chest X-ray, we can see this is the pulmonary artery, this is the descending or called interlobar, which normally should not exceed more than 16 mm, and this is the left pulmonary artery, which will further divide into upper and lower. This image is the same. Here, this is the descending branch of the pulmonary artery, and this is the pulmonary artery. Between the descending pulmonary artery and the superior pulmonary vein, we have what is called the hilar angle, which should, this is the hilar angle, should measure less than 120 degrees. On lateral chest X-ray, the right pulmonary artery is seen end-on and oval in appearance, while the left one is comma-shaped. Since it arcs above the left main bronchus, they may reach up to 3 cm in diameter. This is the frontal chest X-ray showing the right pulmonary artery and the left pulmonary artery, and this is the descending branch of the right pulmonary artery. On lateral chest X-ray, this is the trachea with the bronchus. Anteriorly, we have the right pulmonary artery, posteriorly the left pulmonary artery. On CT axial image, this is the ascending aorta, CT pulmonary angio. This is the ascending aorta, this is the descending aorta, and we have this is the main pulmonary artery divides into right and left. Now the lung roots, the roots of the lungs are formed by structures that enter and emerge at the hilum. They lie at the level of T5-7. The right lung root lies below the arch of the azygous vein, while the left lung root lies below the arch of the aorta. Regarding the right hilum, this is this image of the right hilum. We have 4 structures. Anteriorly, the most anterior, this is the anterior, this is the posterior. The most anterior one, we have the superior pulmonary vein, the most anterior structure. The most inferior one is the inferior pulmonary vein, followed posteriorly by the right pulmonary artery and more posteriorly by the right main bronchus, which is called here hip arterial because it passes above the artery. On the left side, this is the left hilum. The relationship of the veins are the same. The superior is the most anterior and the inferior is the most inferior. The difference is only in the artery and bronchus. This is the artery, which passes above the bronchus and then posterior. Therefore, it is called hip arterial bronchus. This is frontal chest X-ray showing this is the right superior pulmonary vein, the right interlobar artery, the descending branch, and this is the hilar angle. And on the left side, this is the right superior, left superior pulmonary vein and the left pulmonary artery. On lateral chest X-ray, this is the trachea, divides into right upper lobe bronchus, which lies superior to the left upper lobe bronchus. This is the right main pulmonary artery and this is the left main pulmonary artery. And as we say, this is the right bronchus. It is called arterial, so it is above the right main pulmonary artery. While on the left side, the bronchus called hip arterial because it passes below the left main pulmonary artery. Now on sections, on CT sections, we have 3 axial, coronal, and sagittal. On axial view, this is the right root and this is the left left lung root. The right root, if we pass by an axial section here through the right lung root, it is formed by the right superior pulmonary vein, the most anterior one. Okay, this is the right superior pulmonary vein, the most anterior one, followed by the right superior pulmonary artery. This is the right ascending pulmonary artery. This is the main pulmonary trunk, the right ascending pulmonary artery, followed most posteriorly by the bronchus. This is the bronchus. On the left side, we have the left superior pulmonary veins. These are the veins most anterior. Then the bronchus. This should be the level of the bronchus. And most posteriorly is the artery which lies superior-posterior. It will be first superior and then posterior. So this is the artery. So in the right lung, the relationship is valve, vein, artery, and bronchus. In the left, we have VBA, vein, bronchus, and artery. This is the same. On coronal scan, we have 2 planes, anteriorly and then posterior planes. In the anterior plane cutting similar on both lungs is similar. So if we pass from superior to inferior, we will first be passing through the right pulmonary and left pulmonary arteries, and most inferiorly through the right and left superior pulmonary veins. So this is the main pulmonary trunk, the left pulmonary artery, the right ascending branch of the pulmonary artery, and the right interlobar artery. These are superior. Inferior to them, as we can see here, this is the vein, and this is also the vein. This is the left superior pulmonary vein, and this is the right superior pulmonary vein continuing superiorly. So at this level, the anterior level, we have the artery superior. This is the artery, this is the artery, and the veins inferior. If we pass through more posterior sections, the right lung differs from the left lung, because at the right lung, the section will passes anteriorly, first throughout the bronchus. This is the main bronchus. This is the right upper lobe bronchus, and then the artery, and then the vein, either superior or inferior pulmonary vein. So as we can see here, this is the bronchus, the most superior. We say that it is called hip arterial. It will be the most superior one. This is the bronchus, followed by the artery. This is the artery, and followed by the vein. This is the vein. This is on the right side. It differs on the left side because here we have the most superior one is the left pulmonary artery, followed by the bronchus, and then either the superior or inferior pulmonary vein. As it's seen, as it's shown here, this is the artery, the left pulmonary artery, and the bronchus, and then the inferior or superior pulmonary veins entering the atrium. The same image. On sagittal view, the right and the left are identified more easily than the other views, either from the shape of the hilum or from additional features. From the shape of the hilum, this is the right lung root, similar. This is the bronchus, which is called hip arterial. It passes above the artery. This is the bronchus. This is the artery. This is the superior vein and inferior pulmonary veins. the bronchus above the artery. So this is the right lung root. What additional features we have is that we have the right lobe of the liver. So from this we can know that we are in the right lung root, and the ascending aorta. The ascending aorta usually arises from the right side and then arcs towards the left side, as opposite to the pulmonary trunk, which arises towards the left side. So if we see the ascending aorta, then we are in the right lung root. This is an MR image, sagittal view, showing the same relation. This is the superior and inferior pulmonary veins, the inferior vena cava, and this is the arch of azygos vein, through which the hilum passes below. We said that the right hilum passes below the azygos arch. On the left side, sagittal view, we can see this is the left lung root. We have the bronchus, which is called hip arterial, because this is the bronchus inferior to the left pulmonary artery, and this is the vein superiorly and inferiorly. Either from the shape of the root, we can know that we are on the left side, or additional features. What additional features we have here is the stomach bubble, the most anterior chamber, the right ventricle, and the right ventricular outflow tract. As we said, it will pass towards the left side, and the descending aorta. So these additional features help to identify the left lung root. In the same image, but MRI. Additional investigations, we have CT pulmonary angio. It is used to identify the pulmonary arteries, and its main use is to diagnose pulmonary embolism. Normal scan will show the contrast filling the pulmonary vessels, and it will appear bright white. Any filling defect represents an embolus, as it is shown in this section. This is the main pulmonary artery, right and left, and this is an embolus which is called straddle embolus because it involves both bronchs, the right and the left. Bronchial angiogram is useful in the diagnosis and the treatment of hemoptysis. Here, the bronchial arteries are catheterized from the thoracic aorta. Due to variable origin, it may be necessary to catheterize other branches such as subclavian, internal thoracic, or intercostal arteries. This procedure carries risk of spinal ischemia because spinal arteries also arise from these vessels. This is the bronchial angio, showing the right and left bronchial vessels. The MRI is not usually used for diagnosing of lung pathologies because the lung have very low proton density and moves with respiration. And we have an isotope ventilation perfusion scan. This scan uses technetium macroaggregates of albumin for perfusion and xenon or krypton for showing the lung ventilation. This is the ventilation perfusion normally. It's normal perfusion and normal ventilation. There are no filling defects. While this shows a filling defect in the right lung on perfusion and ventilation, this is called matching ventilation perfusion mismatch. Matching perfusion ventilation defect. While this one shows defect only on the perfusion and normal ventilation, and this usually is a scintigraphic image of pulmonary embolism called mismatch. Now, lastly, we have an ABCs of how to read a chest X-ray. First, we have A, which is the airway. Look at the trachea. The trachea should be central and slightly to the right. It should be not deviated. If it is deviated, either it is due to an abnormal patient position or another pathological cause. Second one, you look for the bones, the clavicles, the ribs, the shoulder. Assess the bones for their density, for fracture, or any metastasis or abnormality. Then we have C, which is the heart. Assess the heart shape and size by measuring the cardiothoracic ratio, which should be less than 50% in width. Then D, the diaphragms. Assess both diaphragms. The right is usually higher than the left. Assess below the diaphragm for air. And assess the costophrenic and cardiophrenic angles, which should be clear on both sides and not blunted. Then we have the E and F, the edge of the heart should be clearly visible and there is no silhouetting. The F represent the lung fields and fissures, check for any consolidation or abnormality in the lung markings. Then we have the G, which represent the stomach bubble and the great vessels, the aorta and pulmonary. The hilum, check both hilum for any lymphadenopathy, their size, their position, their shape. And lastly, we have the hidden areas, which may hide a pathology. These are the apical zones, the hilum on both sides, the retrocardiac zone, and the areas below the diaphragm. Thank you for listening. If you have any questions.
دكتور عقيل. دكتور عقيل تسمعني؟ دكتور محمد مهدي.
نعم أستاذ. الأي هو الرايت هوريزونتال فيشر.
رايت هوريزونتال فيشر. اكسلنت. دكتورة كزان بي.
نعم أستاذ. رايت ميدل برونكس.
رايت ميدل برونكس. دكتورة نور بابا سي.
نعم أستاذ. رايت ترانسفيرس فيشر.
رايت ترانسفيرس فيشر. دكتورة نور كاتي.
هذا الأوبليك فيشر أستاذ.
عفوا أستاذ، أوبليك فيشر رايت سايد.
رايت أوبليك فيشر. أوكي. دكتورة نور كاتي.
العفو دكتور. دي رايت لور لوب برونكس.
رايت لور لوب برونكس. دكتورة رنين بقت لنا الإي.
نعم أستاذ. الإي ليفت لور لوب برونكس.
ليفت لور لوب برونكس. ليش قلتي اللور لوب؟ دكتورة رنين ليش قلتي لور؟ ليش مو الأبر؟ يعني الدي والإي إن اللور لوب برونكس. ليش قلنا اللور لوب؟ ليش مو الأبر لوب؟ وهي شرحت قالت at the level of the heart, at the level of the heart posteriorly تبين اللور لوب، بينما at the level of the trachea الأبر. مو صحيح؟
نعم أستاذ.
اوكي، لازم تعيدين المحاضرة تفهميها بنتي.
العفو استاذ، اسمح لي.
تفضل.
استاذ احنا ليش نقول رايت ميدل او رايت هوريزونتال؟ احنا مو نقدر نقول قبل ميدل لانه هو ماكو ميدل بس بالرايت، صح لو لا؟ او هوريزونتال ماكو هوريزونتال بس بالرايت. يعني نقدر نقول قبل، قبل نقول هوريزونتال او ميدل لوب قبل، يعني الا نقول رايت يعني.
لا مو شرط، اذا هو بالليفت اللينجولا وهنا الميدل.
بالضبط. بالضبط.
مو مشكلة، بس هو احنا من نقول رايت وليفت مو هي انه، وانما للمقابل من تكتب ريبورت وهذه حتى تحدد، لانه الليجن عندك بالرايت يختلف عن الليفت.
طبعا نعم.
فاذا هذا التقسيم اللي قسمته الريد لاينز اذا تتذكر طبعا مهم، حتى فهو قايد لاينز لكم بين الابر لوب واللور لوب والهذا. عندك بعد مو حتى استاذ محمد يكمل؟ استاذ محمد. استاذ محمد تفضل.
عمر فهمي.
نعم استاذ. قالت شيء. رايت ميدل لوب.
رايت ميدل لوب. لارا نصير.
نعم أستاذ. رايت أوبليك فيشر ميجر.
رايت أوبليك فيشر. مريم
نعم
الأخضر.
دكتور.
الأخضر
الأخضر رايت لور لوب.
مريم وياكم؟
نعم دكتور جاوبت رايت لور لوب.
جاوبته.
رايت لور، تمام. حيدر كريم.
نعم أستاذ. الأزرق
نعم.
اللينجولا of left الأبر لوب.
جيد. لينجولا في لفت أبر لوب. زين. علا صريح. علا.
نعم دكتور. left oblique fissure.
left oblique fissure. وعندنا رشا داخل.
نعم أستاذ. left lower lobe.
left lower lobe. ممتاز.
شكرا جزيلا دكتورة ليندا. طبعا